Buonasera a tutte e a tutti. I would like to welcome our attendees to tonight's webinar held by Professor Maria Garassino, Professor of Medicine and Director of the Thoracic Program at the University of Chicago. Thank you very much, Marina, and for accepting our invitation. I would also like to welcome and thank Eleonora Forte, researcher, assistant professor at the Feinberg School of Music of Northwestern School of Medicine of Northwestern University, and president of the Chicago chapter of iRicerca, the Association of Italian Researchers around the world. And this webinar gives us the opportunity to renew our cooperation with iRicerca in the aim of disseminating scientific culture. Lastly, I would like to thank Consul General Thomas Potzios for joining us for his welcome remarks. As usual, I would like to remind you that the webinar is being recorded and it will be soon available online on our YouTube channel. Lastly, I would like also to encourage you to engage in a conversation with Professor Garassino at the end of our presentation in a Q&A session that will be moderated by Nora. And therefore, I would finally like to leave the floor to Consul General Thomas Potzios and afterwards to Eleonora Forte and Marina Garassino for tonight's webinar. Thank you very much. Please, Consul General.
Thank you. Thank you, Director Di Vito. Good evening, everyone. And I have to say that I'm always glad to have this kind of opportunity for 2-3 reasons. And first of all, because it's always important to listen to scientists when it comes to speak and talk about such important topics that have an impact on our on our own lives, I would say. And second, another reason, and I think it's very important to talk about these topics, because it's now almost 2 years that are facing and having such hard times due to the pandemics. But I'm sure that if we had statistics on that, we would find the word COVID and related words as the most pronounced by everyone in every day of our life. But there is a high risk to forget other pathologies, other patients that are still in our lives. So it's really important to pay attention and to listen to prominent scientists on these important topics. And third, of course, because Dr. Garassino is a prominent scientist and is another brilliant example on how the community of Italian scientists and researchers are contributing to the development, to the this important sector in the United States society. And so as Consul General of Italy, I cannot be but proud of that. So I really thank Dr. Garassino for her lecture. And I would say thank you to iRicerca and President Eleonora Forte for this opportunity, and give them the floor right now. Thank you. Enjoy the evening.
Thank you very much. Thank you all for joining us today for the last webinar of the year organized by iRicerca, Chicago chapter, in collaboration with the Italian Cultural Institute of Chicago. I would like to thank the director of the Institute and the Consul for their continuous support to our association outreaching activities. If you would like to know more about iRicerca, please find us on our social media or see our website, iricerca.org. There you could find the page dedicated to our chapter with our activities and the previous webinars. So let's get started with the presentation of today. It is really a pleasure for me to introduce Dr. Marina Chiara Garassino, who kindly accepted our invitation. Dr. Garassino is an internationally recognized expert in the treatment of thoracic malignancies, including lung cancer. She graduated from Medical School of University of Studies of Milan, Italy, where she also completed her training in medical oncology. After a fellowship in Manchester, UK, she served as a physician oncologist in prestigious Italian cancer centers. She led the thoracic medical oncology unit in one of the most important comprehensive cancer centers in Italy, the Istituto Nazionale dei Tumori in Milan. And she recently joined the University of Chicago as professor of medicine in the section of hematology oncology. Dr. Garassino is an outstanding physician scientist who has contributed to the development of oncologic precision medicines and immunotherapies to improve the quality of care and outcomes for her cancer patients. She authors over 200 publications, including several which have radically changed the treatment paradigm and treatment guidelines for lung cancer. Today, Dr. Garassino will talk about the new frontiers in the treatment of lung cancer and other tumors. Furthermore, she will discuss the impact of COVID-19 on cancer patients and the importance of vaccination in this category at risk. As the director was saying before, at the end there will be enough space for a Q&A, and please use the Q&A feature or the chat for making your question. Thank you, Dr. Garassino, for being with us tonight, and you can take the floor. Thank you.
So thank you, first of all, for inviting me. I tried to simplify as much as possible. There is my research of the last, I think, 15 years, more or less. And we will go through the new treatments, in particular the immunotherapy and the targeted agents. We will review something about the screening, because I truly believe that the prevention, in particular in lung cancer, is very important. And there will be something also about the COVID and cancer. So I was in my career very lucky, because when I started to treat lung cancer, the prognosis of patients with lung cancer was about 1 year. So basically, you didn't have time enough to meet the people, because they died very early and very quickly and in a very bad situation. So during my career, I had the incredible honor to see at least 2 revolutions. One was for the target therapies, and the second one for the immunotherapy. And I was very also honored to be part of the story of lung cancer. So basically, when we speak about lung cancer, we speak about 2 different tumors. One is called small cell lung cancer. It was identified in the end of the 70s by the Manchester group where I was in the 10 years ago. And the other one, which is much more common, is non-small cell lung cancer. So when we speak about lung cancer in general, we are speaking about non-small cell lung cancer. Small cell lung cancer is a particular tumor type which is very sensitive to the chemotherapy, and in general is not surgically resectable. So from now I will speak mainly about non-small cell lung cancer. Again, non-small cell lung cancer is divided again into big categories. One is the category of the people who never smoked, and the other one is the category of the people who smoked. So when I am in the clinic, I have always a patient who asks me, I had my grandfather who never smoked and he had the cancer. Yes, this is possible also in the never smokers. Just to give you a percentage, the lung cancer in never smoker accounts about 15% compared to 85% in the people who smoked. There is a lot of discussion in the last years about the stigma of smoking. We have to think about that smoking is an addiction. And so the people who smoke must be helped and not condemned just because they are smoking. But we clearly have to help these people, because unfortunately, lung cancer now in 2021, it is the major cause of death for cancer for all the other tumors. So it's much more than breast cancer and also other tumors. What is very different from the people who never smoked and the people who smoked, there is a kind of intersection of the two words, but this was just to simplify the message, is that in the people who never smoked, and you will see in the second part of the presentation, we were able to find a lot of targetable alterations for which it is possible to treat these patients with oral drugs. And for each one of all the targets that you can see here, there is one potential target therapy. On the other side, for the other 85% of the people who smoked in the past, the immunotherapy is I would say the cornerstone of the treatment for this kind of patients. So just to think about the immunotherapy was clearly revolutionary in the last 10 years. And it is a very nice story because it started about 2 centuries ago. The first of observations were done by William Cole in Memorial Sloan Kettering in New York. And he treated about 1,000 sarcoma patients with some intratumor bacteria injections. And he was able to prove that there was a benefit in giving Serratia marchaceans and also Streptococcus pyogenes in treating cancer. So he observed that there was something that was able to activate the immune system against the cancer. And this is the first observation that we had. Then there was, in the same period, there was another group of scientists, in particular, maybe you know the name of Albert Calmette and Camille Guérin. And they started to use the tuberculosis bacteria, in particular, which is called Calmette and Guérin bacteria, to treat the bladder cancer. Just to give you an idea, still now in 2021, the BCG is still used to treat the bladder cancer. And the idea was that we were able to create a sort of inflammation, and the inflammation was able to cure the bacterial infection, but also the cancer in these patients. And then there is a lot of people that had very similar observation. Just these people were I think the fathers or the mothers of the treatment with immunotherapy. And these people created a sort of paradigm that we could use the immune system to treat the cancer. And as you can see, starting from the end of the Second World War, there was a lot of attempts to use the immune system as an oncological treatment. But unfortunately, in the last century, we saw a lot of failures in the treatment with the immunotherapy, because basically the scientists tried to use the immune system to create some inflammation. Some of them, they tried to create some vaccines against the cancer, but all these attempts failed. And we understood just in the last 15 years why they failed. And maybe all the research that was done in the last century, we will have a new life, because now we know much more about the immunology in cancer. The study basically started in the last 10 years. As you can see, the major scientific journals published a revolution, a breakthrough with the immunotherapy in the world, and in particular also in the United States. You can see the image of Biden. They created the Moonshot Project. That was a very ambitious project to cure the cancer. And they immediately recognized that the immunotherapy could be one very important part for the treatment, not just for lung cancer, but for all the cancers. So just to give you an idea on how the immunotherapy works, there is a theory for which it is called the theory of the tree. Now maybe we are moving forward this theory, but it's still a cornerstone to understand how the immunotherapy works. So the theory is that in the first part, when we have just a few cancer cells, the immune system, you can see what is called the CD8, CD4 are the T lymphocytes that we now know very well for COVID. And they are able to attack the tumor and they are able to eliminate and destroy the tumor. Then there is a second phase, which is called equilibrium, where the tumor is growing, there are other cells coming, and so the immune system is losing power. And in the last phase, which is called escape, and it is the phase when we diagnose the cancers, you can see that there is the tumor is able to avoid the elimination and is able to escape the immune system. There are many reasons why the tumor is able to escape the immune system. As you can see here, there are some negative components of the immune system, and there are some reasons why the tumor is becoming more clever and is able to evade the immune system. And so all the research of the last years is focusing more in the escape, and before was focusing more in the elimination and the equilibrium. The second concept is that we have at least two types of immunity. One type is called innate immunity, which is characterized by a very rapid response. And it is also characterized by just 200 types of receptors. And then there is another type of immunity, which is called adaptive immunity, which is characterized by a slow response, but it has memory. And we know very well from the vaccine, because we use the vaccine because our adaptive immunity has a memory. And so if it recognizes something in the COVID, can be the cancer, can be something else, our immune system, in particular the adaptive immunity, has a memory. So when the adaptive immunity sees again the enemy, is able to recognize and to attack the enemy very quickly and in a much more precise way. Clearly, the cells are talking each other. And what we understood in the last years, and there was an incredible Nobel Prize in 2018, I think that was one of the most relevant for the cancer treatment. And in particular for lung cancer, we must thank in particular the Japanese scientist Onkyo, but also Ellison was very important, in particular for other tumor types like the melanoma. What they discovered was a very simple concept, as always in the science. So as you saw before, all the science in the last century was concentrated in the activation of the T cells against the tumor cells. But they discovered that we have some signals that they are able to shut down the immune system. And this is true for lung cancer, this is true for all the tumor cells, and this is true for the virus. And if you think this is very rational, because, for example, if we have the flu, we have one part when the inflammation is very active and very high, and we have a lot of symptoms, and then we recover from our inflammation. So it is clear that we need to have something which is able to activate the immune system, but we need something which is able to shut down the immune system. And so what they discovered is are some signals, in particular PD-1, PD-L1 is one of the most important. And they discovered also that to activate the T cells, we need a recognition of the enemy, in this case can be the tumor cell, and we need a co-stimulatory signal. So only when we have the co-stimulatory signal, we can activate our response, and we have some signals that they are able to shut down the immunity. And so this is the most relevant way on how the tumor is able to evade the immune system. What you can see here is this is just to give you an idea. This was done in 2013, so eight years ago. you can see that we discovered very quickly a lot of co-stimulatory and a lot of co-inhibitory molecules. And now in the pipelines of the majority of the pharma companies, there are drugs able to target all these signals that are able on one side to activate, on the other side they are able to decrease the activity. So basically what we are doing is that we are inhibiting the inhibitory signals, and in this way we are able to reactivate again our immune system. The study is not so easy, and I like this image because can give you the idea of the complexity of what we call tumor microenvironment. So the tumor microenvironment is an environment where there is the coexistence of tumor cells and a lot of immune cells, and they are speaking each other. So, and if you have one part which is more than the other, you can have more evasion. And if you have the other one which is more pronounced, you have more activity. So this is just to give you an idea how much is complex the immune system. Clearly, what we, Onkyo, discovered the PD-L1 signal. So PD-L1 that we can find on the tumor cells. For the people who can understand that this is the expression of PD-L1 on the tumor cells, but it can be present also in the immune cells. We have as more as we have PD-L1 expression, as more as we have activity of our compounds. So the study that we saw in the last years, this is clearly a simplification, is much more complex, was done by two very important papers that were published several years ago on the New England Journal of Medicine, which for us is like the Bible of the medicine. One was the first case for which we saw that the immunotherapy in this case is called pembrolizumab, but is not the only one. There are many others, nivolumab, atezolizumab, durvalumab, they are basically all the same, was superior to the old chemotherapy in patients PD-L1 positive. I don't ask you to understand the Kaplan-Meier curves, but just to see that the survival rate of the people who received the immunotherapy was much higher, just as a single agent was much higher compared to the people who received the chemotherapy. And just to give you an idea, the immunotherapy is very well tolerated. The patients, they have less side effects compared to the chemotherapy, and they live for a long time. What you can see here in the red curves, there is a tail of the curves for which we have patients that are still alive after many years. And for example, I started to do clinical trials with immunotherapy, and still now I have patients that are alive after 8 or 9 years. And I can tell you that before they could just die in a few weeks or months. The other important paper, and I was very honored and lucky to be the last author and the principal investigator of this trial, was again on the New England Journal of Medicine. And when I started the trial, there was the idea that combining the chemotherapy to the immunotherapy, you could exploit the synergistic effect of both, and you can have much more responses, and in particular in the category of patients who had the PD-L1 that was not so high, this could really change the life expectancy of the people. This was true because as you can see from the green curves, there was a reduction of the risk of death of about 50%. This was, for me, it was an incredible experience to see the results of this trial. And again, there is a tail of the curves of people that can survive 4 years. Clearly, combining the chemotherapy and the immunotherapy is more toxic than just giving the immunotherapy alone. And this combination is basically for the people who have PD-L1 level that are lower than 50%, where the immunotherapy alone is not enough. The other part, so this was for the immunotherapy. The other part that was before the era of the immunotherapy was the treatment with target therapies. So maybe in Italian you can speak about farmaci biologici or target therapies in general. They are, the majority of them, they are oral drugs, and they are very well tolerated, and they give a very long prognosis to our patients. So we are speaking about years for these patients. The majority of them, they are represented in the category of patients who never smoked, and this study was fascinating as well. So gefitinib was one of the first targeted agents that was created in the end of the last century. And this was an EGFR tyrosine kinase inhibitor. And EGFR is epidermal growth factor receptor. So you can understand also from the words that epidermal is everywhere. And so we started to give the drug to all the patients independently by the presence of EGFR mutations. In 2004, two groups at the same time in the United States started to think that they could see more responses in some patients who never smoked, and in the majority of patients were Asians. So they started to sequence the genome of the tumors, and they found that all patients who responded very well to gefitinib harbored EGFR mutations in the tumor. EGFR mutations means that you have your exon, and we don't know why. In particular, in two parts, which are the exon 19 and the exon 21, there are particular mutations that are giving a special sensitivity to this kind of drugs. And so I don't want to, I want to make the story short, but in the last years, there were a lot of trials comparing the old chemotherapy to the EGFR inhibitors, and for all the EGFR inhibitors became superior to the old chemotherapy. This was just the first example, because in the last 15 years, we discovered many other targets: ALK, ROS1, BRAF, RET, HER2, MET, exon 14, TRAC, KRAS, and last week also CLIP1. And for each one of them, there is a special drug able to target specifically the mutations and the gene. And I can tell you that it was incredible, because you can see that the tumor, the shrinkage of the tumor in few weeks, and you can see that maybe very sick patients, they can improve in very few weeks, and they can come back to the normal life. Just to show you that for all these targets, we have a drug, and we understood in the last years that they are more or less like antibiotics. So after a certain period, you can develop resistance to this kind of drugs. And we found also the next generation of the drugs. So for example, for the ALK patients, you can start with alectinib, you can move to brigatinib, you can move to lorlatinib, and so on and so forth. So for these patients, the life expectancy can be years, can be truly years, with a very, very good quality of life. And they just do their normal life, and they have just to take an oral drug. What is really important, and I just want to give you an idea that sometimes the research is going so fast that is also difficult to incorporate all what we find in the clinical practice, in the daily clinical practice. These are data presented in ASCO. ASCO is our most important congress for oncology in the world. That is, in general, it is done in Chicago in the first week of June. This year clearly was just a virtual congress. And there was a study showing, you can see all the centers included in this analysis that were everywhere in the United States. So in a very technological environment. And what you can see is that only less than 50% of the patients were tested for all the biomarkers that I showed you before. So this means that the lung cancer is becoming so complicated that you need a particular team to take care of lung cancer. And for example, what I suggest to all the people is on how to select a good center to be treated. What you need is a multidisciplinary team. So to do correct diagnosis for your patients and to do a correct treatment, you need to have at least the oncologist, the surgeon, the radiologist, the pathologist, and the dedicated radiologist for this team. Just to give you an idea, this is the group at the University of Chicago, and all the Wednesday morning we are just seeing all the cases at the University of Chicago, because if you miss the target or if you do a wrong diagnosis, you can totally change the life and the prognosis of the patients. Having said that, that is very important, but is mainly for patients with advanced disease. I always say something also about the screening, because it is true that with the immunotherapy and also with the target therapies, you can have a prognosis of years, but you will be forever on treatment. And with the screening, we have the incredible opportunity to have an early diagnosis, to have a surgically resectable cancer. And so potentially these kind of patients are cured. And what we know is that, again, from the New England Journal of Medicine, this was a trial done by the, in Bethesda, by the NCI in the United States. They were able to prove that the CT scan, this is a cumulative incidence, the CT scan, the low dose CT scan was able to increase the early diagnosis, and it was much better compared to the chest X-rays, to the chest radiography. So for after 2011, the screening is not with the chest radiography, but must be done with the low dose CT scan. And this was the trial, was about 15,000 volunteers. There was a very good follow-up, and the volunteers were included, and there was an incredible benefit in the trial. But the European people didn't think that this was a good trial, and so, you know, that Europe and US, they are always doing similar things to prove that they are correct. This was the European trial that was published 1 year ago. It was the Nelson trial. Again, 15,000 volunteers, and they were able to prove that the CT scan was superior to just to monitoring the patients in finding early cases. And in particular, there was a particular phenomenon that was recurrent also in other screening programs, that was that the females, heavy smokers, benefit more of the screening compared to the males. We don't have an explanation to this phenomenon, but in particular, the majority of the benefit of the screening is in the females compared to the men. I'm not saying that the males don't have to do the screening. I'm saying that all the smokers must do the screening, but in particular, the females. How can you consider the at risk? We consider at risk all citizens, because they don't have the cancer, with an age more than 50 and with a history of smoking of more than 30 packs per year, which means that 2 packs per day you can just multiply 2 packs per day for the years you smoked, and you can find your risk. To the question if the people who quit smoking, they are still at risk, the answer is yes. We believe that after 15 years, more or less, they have the same risk of the normal population. But there is always time to stop smoking because there are other benefits, not just the decrease of the risk of cancer, but there are benefits on the cardiovascular system, on many other, for the women, for the wrinkles, and many other reasons to stop smoking. What I think it is important for the United States is that in the last weeks, the Association of Chest Physicians reduced the number of PAC years to 20 based on the results of the European trial. And I think that is also important to remember that the majority, I would say all the insurances are paying for the screening. So this is not an economical issue, at least in the United States. And there are also some population data that they are suggesting, as you can see here, that for the patient who are screened, there is an increase of the localized disease compared to the decrease of the advanced disease for patients when the screening started in the United States. These are just some emails for the people that they are listening. If you want to do a screening in my university, maybe you can have this address, but you can find many other in the web. A few words just on COVID, because I believe that this is, as we said before, is the most pronounced word in the last 2 years, unfortunately. I made a lot of research for COVID and cancer because just I was in Milan when the pandemic started. And we were able to prove that there was an increased mortality for patients with cancer and COVID. The mortality is very high. In particular, we believe that it is between 15 and 30%. In particular, for lung cancer is 32%. And the mortality is still high for patients who are not vaccinated. So I think that in particular, lung cancer patients and also hematological patients that are at higher risk of mortality for COVID compared maybe to patients who have just prostate cancer or other tumors. But the mortality is very high. And this was the reason why we made a call to action also to the European Parliament. I was the lead of this project, and we were able to convince the majority of the member states to give the vaccination immediately to the cancer patients and not just based on the age. If you remember, 1 year ago, we started to vaccinate before people that were older than 75, than 65. And so with this call to action, we were able to convince the European Parliament to ask to the member states to consider the possibility to increase the vaccination campaign for cancer patients. What we know is that clearly the trials for the vaccination were done in healthy volunteer, but there was a number of patients who had some types of cancer, and in particular breast cancer, prostate cancer, melanoma, and some hematological condition. And the subgroup analysis was done to see if the safety of the vaccination was similar to the normal population. And as you can see here, the safety of the patients who with a history of malignancy was exactly the same to the overall population. And again, there are maybe 300 articles now in the literature. This was a very nice meta-analysis showing that the safety is exactly the same to the normal population, but it seems that there is less immunization for patients with hematological malignancies, and maybe there is also less immunization for patients who are on chemotherapy and on steroids. Having said that, I think that is really important to promote as much as possible the vaccination everywhere, but in particular in cancer patients, because the mortality is so high that we can't risk to stop the treatments, and we can't risk to lose the patients just for the vaccination. So to conclude my presentation, I know that I told you many things, but just to give you an idea, I told you maybe 1% of the knowledge that we have now for the treatment of lung cancer. But for my life, it was an incredible experience to see in the last 15 years the revolution that we had before with the target therapies, starting from 2004, and with immunotherapy later. I would remind you the importance of the screening and the importance of COVID-19 vaccination. And I would like to conclude also to say that everything that I made was done in Italy. And we must be proud of the Italian research. I think that the level of the research in cancer is very similar to what I found here in Chicago. And I think that there are a lot of also Italian brilliant minds in the United States working on cancer. And thank you for inviting me. I was very happy to be with you today.
Thank you very much, Dr. Garassino, for this comprehensive overview on new therapeutic strategies to treat lung cancer and your data on vaccination. I hope that that will be an input for people who are still hesitant in getting vaccinated to get vaccinated, especially if they are cancer patients or family member of cancer patients. So we now can open floor for discussion and Q&A. So if you have any question for our speaker, you can use the chat feature or the Q&A. I can start with one question, giving more time to people.
There is also one question in the chat, I think.
Sorry?
No, there is one question in the chat.
Okay, let me see. Okay, so what's the current state of predicting response to immunotherapy?
So yeah, thank you for the question. This is clearly a crucial question. And I showed you the tumor microenvironment and the complexity of the immune system, just to explain where we are so far for the predicting the benefit of the immunotherapy. At the time being, at least for lung cancer, the PD-L1 is still the most relevant biomarker. There is a part of the research working on the neoantigens and also on the tumor mutational burden. So we are basically, what we believe is that in general, the immune system does not recognize the tumor because it's very similar to our normal tissue. And when we have a lot of mutations, it is possible that you can create some mutations that can help the immune system to recognize the tumor. And so the tumors with more mutations and more what we call tumor mutational burden maybe can respond better, but they are just one part of the story, because we are working now also on the innate immunity, which can have also some pro-tumorigenic effect and can create problems to the prediction of the benefit of the immunotherapy. I was very complex in my answer, but just to tell you that we are very far from a good prediction of the immunotherapy.
Thank you. We have also another question from Andrea Piunti. He congratulates for a fantastic talk, and he was wondering if it is known whether receiving immunotherapy will affect the response to the SARS-CoV-2 vaccine.
Well, this is another very important question, and there is a lot of research on that. For example, there is an old literature from the flu vaccine, and for the flu vaccine, we know that there are no more side effects, and it seems that there is more oncological activity of the immune checkpoint inhibitors together with the flu vaccine. So we are not sure that because clearly the results and the maturity of the data is not so high, but it seems that the activity of the vaccine is more when we are on immune checkpoint inhibitors. And there are some very preliminary data that maybe they can help also to increase the activity against the cancer. So I'm not saying that is black and white, I'm saying that perhaps.
We also have another question. So is genetic screening for all the targets you mentioned done routinely, or is done only after other options fail?
Say it again, sorry.
So basically, Fatma wants to know if the genetic screening is done for all the targets at the beginning routinely, or is done after one treatment is failing and then you try something else.
Yes, sorry, I didn't. So must be done immediately. So for the diagnosis of lung cancer, you can't touch a patient if you don't have what we call NGS, which means next generation sequencing. And it means that we are doing all the genomic screening for all the targets that I showed you. And then we can start the treatment. And this is for two reasons. The first reason is that because in general, the patients who have genomic alterations, they do not respond to the immunotherapy. So you risk to treat these patients just because you think that they do not have genomic alterations with immunotherapy and without any benefit. The second reason is because if you find the target, you have the targeted agents and you can give just an oral drug to the patients, and which is much more easier than giving chemotherapy, immunotherapy, or whatever. So it's mandatory in 2021 to start the treatment for lung cancer only if you have PD-L1 and all the 8 targets.
We have also another question. What are the perspectives for lung cancer treatment in the next 10 years?
Well, I would like to have the crystal ball. So there are, I think that there are two important fields. The first is how we continue after the first generation immunotherapy. And for this, we are working on multiple possibilities. First of all, we are trying to find other targets. It seems very difficult because many targets failed. There are what we call adoptive therapies, which means the engineering of the immune system against the cancer. Maybe you heard about the CAR-T, which are now part of the treatment of the hematological malignancies. But they are not just the CAR-T. We can potentially engineer also the macrophages. We can potentially engineer also the other immune cells like the NK. And clearly the huge problem that we have for the other category of patients with target therapy is that every time you move to another targeted agent, you create heterogeneity. So the problem is to find a way to go out from the heterogeneity of the tumor. There are new agents. Maybe you heard about the antibody drug conjugates. The antibody drug conjugates can become potentially the new immunotherapy, the new chemotherapy. And basically they are one part, which is an antibody, and the other part is a cytotoxic part. And there can be another new wave of treatments. And there is also the possibility to target the metabolic vulnerabilities. So there is so much going on in this field. It's really difficult to give a final question, but I'm sure that in the next 2 or 3 years, we will see much more of that.
All right. there are no other questions there is another question. So Fulvia Berton said, you said with the new treatments, immunotherapy, the patient gains several years, but there is not a forever cure.
So, I give you my experience. So I started to do the clinical trials with immunotherapy in 2012, 2013, so in the early beginning of the study. And after 9 years, I have patients still alive, and some of them are without the treatment. So we don't know if these people are cured or not, because we are scared to say that they are cured. Perhaps they are cured. But I don't want to give false expectations. I just say that the prognosis of the patients is now, for a large group of them, is very long. So I hope that they are really cured.
Thank you very much, Dr. Garassino, for being with us tonight and for the wonderful talk. Thank you for all the people who joined from home. Stay tuned for our next event. And for me, it's all happy holidays to everybody and stay safe. Director, you want to add something?
Absolutely. On my end, I would also like to thank you, Eleonora, and thank Professor Garassino for this enlightening presentation. That for myself, besides, I would say the more medical and technical, scientific part, I was very touched by your passion, the passion of a person who has not only witnessed, but also been part of this dramatic and extraordinary evolution in the treatment of lung cancer. So thank you also for this, for sharing this with us. Thank you again. As I said, we are renewing our cooperation with Ricerca. That will for sure continue next year. And I join Eleonora wishes for happy, serene holidays to everyone. Therefore, thank you very much, and we'll see soon each other on these screens. Thank you.
Bye.
Bye-bye.